Thank you very much, Ivan. That was an excellent overview of a fairly common problem in the cardiac cath lab. Obviously, no one wants to see hypotension, and it's important to look at the blood pressure before and after every injection. And just be ready to find the underlying cause and try to correct it. And of course, we'll have support devices, but the key thing is to find the differential diagnosis. Jader, do you have any tips and tricks of how do you approach it? Do you give vasopressors quickly, or do you wait, or any thoughts on how you approach hypotension?
I think, as Evan said, there's a wide differential. And to me, the most probably common things are related to things we do in the cath lab, like nitroglycerin or other medications. And I think essentially having a lot of equipment within the guide or the hands on the TUI or things like that. So those are I think the most common things. And if those things are checked and that there's not an issue, I think we have to go outside of that. Is there a growing hematoma in the groin? What's the heart rate? Is the patient responsive? Have we given too much sedation? So I think those are the things that you just have to go on a systematic fashion until you find the cause. And if you don't find a reason, the patient continues to be hypertensive, they're not responding to your usual ABCs of evaluation, then maybe you need to give a little bit of phenylephrine and continue to evaluate further and go from there.
Yeah, thanks, Jader. Kate, I know that you've very experienced in handling some of these tough complications. What is your threshold for putting a Swan guns in? Do you use Swan guns quite a bit?
Yeah, I was just thinking, I think like kind of knowing your hemodynamics up front from just your history of the patient, and sometimes an LVEDP at the beginning of a case, if you know it's high risk for causing ischemia in particular, just gives you some sense of where you are. But I do think in these cases, when you get to a point of stability, if we're not sure what's going on, that's where the Swan is so helpful. A lot of times, there's been a couple of cases where we've missed that, there's like RV free wall hematoma or something that's not even obvious. The perf might even not be that apparent right now, but they're having some RV failure from that. We're not seeing true tamponade physiology, but some dysfunction related to that. And I think we often forget that, even in an emergency, we get the Impella in and we're still struggling. People forget that we don't know what's going on in the RV without the Swan. So that in particular, when you get to a point of calm, it takes 5 minutes at most to get the neck prepped and get it in. So I think that can be really helpful.
Absolutely. Any other thoughts from any other panelists before we move on?
The right heart catheter is really, I think, key. We've actually had a case not too long ago of a biradial C2 intervention where we just could not get the patient stable and ran down the differential, couldn't find anything wrong. And ultimately, it was a right heart catheter that confirmed that he had very, very low filling pressures. And it turned out that he was bleeding from his brachial artery. So this is something to be aware of as we adopt radial for these more and more complex cases, that not all radials are going to be benign. There can be these unusual bleeding complications. And when you can't make sense of it, put a right heart catheter in to try to narrow your differential.
Yeah, and another point that I want to make is sometimes when you do RCA PCI with AL1 guide or AL guides in general, you might have interference with the aortic valve. You might have some moderate to severe AR, and so that's the cause of your hypertension. So you have to pay attention to that and move the guide catheter, especially if it's the AL.
Perfect. I think, Dan, you're going to say something?
No, that's a great point, and I really support the right heart cath strongly in this situation. The other thing that we've had a few times is a loose connection. You just can't figure it out. The patient looks okay, but the pressure is down and there's a loose TUI or a loose connection that you just had not appreciated, and it solves the problem. So just got to keep thinking it through as the algorithm points out. I agree.
I think that's a really good point. I feel that happens a little bit more when you're using the assist device rather than manifold.
Yeah.
And don't forget contrast reactions. That's an important differential. Contrast reactions can be very severe and be associated with significant hypotension. So that should also be in the differential, not in the middle of the PCI because you already given the contrast, but when you're starting in case you have significant hypotension, can't explain. Just think about contrast reaction right away so you can treat it.
Valvular patients, I see we do a lot of coronary interventions in severe AS patients sometimes, and those you have to really be careful about dropping the blood pressure because it's very hard to bring them back, and probably you may need an emergent balloon valvuloplasty if they don't come back with your basic intervention. So that's one thing to